and politics. Do take a look at our public policy education programs. They are definitely tailored for especially people like you, and they're online and you can take them from anywhere. We have both one semester certificate programs as well as year-long graduate programs in public policy, defense and foreign affairs, technology, health and life sciences. And do stay tuned to our newsletters and listen to our podcast. And for this evening, we have our host, Shambhavi Nayak, who's head of research at Takshashila Institution. So over to you, Shambhavi.
Thank you, Soumya, for the introduction, and welcome everybody to today's book discussion. In recent memory, there has been no other disruptive and life-changing event similar to the COVID-19 pandemic. In December 2019, we saw the outbreak rise in China like a tidal wave. And in a span of few months, it engulfed the whole world. The only escape seemed to be to hunker down in our own social bubbles. COVID-19 has captured our imagination in a way no other disease has managed. The disease outbreak was accompanied by a tidal wave of information. The WHO called it an infodemic, as information, right, sometimes wrong, or sometimes simply premature, came streaming in. This infodemic paid testimony to the old philosophical adage, there is no truth, there is only perception. Truly, social media fueled an onslaught of perspectives about the virus, its origin, diagnosis, and treatment. But the world of science does not work on perspectives. Science is data-driven, evidence-based. In the face of this mystery virus, facts and data remain the primary weapon in the armory of scientists, physicians, and policymakers. Any strategy against COVID-19 had to be rooted in facts. A little over a year since COVID-19 took center stage in our lives, perhaps this is a good time to reflect on what we have learned about this disease over the past year. But how does one sift through all the information onslaught to identify the facts? Luckily, our job has been eased by our guest of honor today, Anirban Mahapatra, in his excellent book, COVID-19 Separating Fact from Fiction, published by Penguin Books and available for sale on Amazon. He deftly blends his training in microbiology and expertise in science publishing to comprehend and present the various aspects of COVID-19, the virus, its origin, its impact, and the global response. What I loved about the book was that it made the science of COVID-19 accessible without shying away from the complexity of the challenge, particularly early in the outbreak, when there was little knowledge about the virus. Making the choice of treatment, vaccine, and diagnostic strategies was difficult. The book lays out this landscape and demonstrates how we have made progress to 2020 in understanding this virus and its spread. One guiding factor that the book consistently refers to is past pandemics, and in doing so, factually lays out the groundwork to learn the lessons for future pandemic preparedness. To discuss insights from the book with Anirban, we have three discussants. Madhura Lohia is a scientist and entrepreneur with a background in cellular and molecular biology. Vinayak Jain is a medical doctor with interest in public health. Both Madhura and Vinayak are also interested in public policy and are participants in Takshashila's graduate certificate program in health and life sciences. We also have Ms. Pranati Rao, who is a fourth-year undergraduate student at West University and has an interest in bioethics. Pranati is currently researching vaccine diplomacy at Takshashila. I would also like to welcome our audience to this event, and we look forward to your cooperation and participation. Please post your questions in the Q&A box, and we will take your questions in due time, with a commitment to discuss as many questions as time permits. Now let's turn to our book conversation. Before we talk about COVID, I have a couple of fundamental questions to ask Anirban. My first question is something that researchers always grapple with: when to decide that a project is complete? Like any thesis of this nature, were you tempted to hold off the publication till you got more data? I think the basic question is, why this book and why now?
Well, first of all, thank you for having me, and thanks to all the participants who joined on a Friday evening in India or Friday morning or afternoon elsewhere. It is currently about a little past 8 a.m. in the United States where I'm based. Thanks to Takshashila Institute for hosting this event. It's a great question. When do you start to or when do you feel that you have enough information to write about a pandemic when you're in the middle of a pandemic? Early on, the information that you have is going to be very useful. People will find it of immediate value, but it's going to be incomplete because not all the information is out there. If you wait too long after the pandemic is over, then some of the practical information becomes of limited use as well. So there are basically two approaches that we can take. We can take the approach of a science writer or a communications aspect or a researcher who's looking at something in the past. And what they have is the benefit of going through the entire body of references and then sitting down and with the whole stack of papers and saying, okay, I'm going to sit in my cave and research this for about a year or so. And then I'm going to go through, after I'm done with the research phase, I'm going to start writing my book. And we don't have that luxury during a pandemic. So what we have to do is more on the mode of what a researcher does with the project that they're undertaking right now. And in this way, I was definitely guided by the approach of one of my mentors or someone I admire deeply, who is chemist professor George Whitesides, who wrote a very nice perspective a few years ago. And he said, basically, if you wait for a project to finish, then you'll never get done writing the paper because projects are never done. Information changes over time. So the research and the writing process have to go hand in hand. You start immediately. So this doesn't mean I started in March, but there was a time that I was actually collecting papers every day and writing short summaries. And the advantage of that is that your information is accurate, you have information. The disadvantage of that is that you have to go through multiple drafts. And I think I've gone through, especially with the vaccines chapter, I started writing it when vaccines went into trial. And then I continued writing it. And then obviously now we have vaccines. And we have sort of this situation of post-vaccine launch hesitancy as well, where people are not taking it up. So I think that's a great question. Thank you for that.
Thanks. That reminds me of a proverb that I had in my PhD laboratory. A thesis is never finished, it is abandoned. And I guess, yeah, the trade-off is always when do you do that? I have a follow-up question before I get to the discussions. And that's about how you separated fact from fiction. How do you objectively look at something you have found and liked, but you realize that this might not be the complete data that you need, and you think that maybe this falls in that gray line, right? How do you objectively look at fact and fiction?
Yeah, I think social media has been good for something in this way, in that it's basically helped me to hone the message, see what people are interested in, and basically communicate on a real-time basis. I think what a book allows us is it allows us to step back a little bit and take a deeper dive, as opposed to someone who is looking at the numbers on a daily basis or is commenting about something that's out there. They don't have the luxury of being able to, as you mentioned, go back and put this into the context of other diseases and other factors. So the book ended up being around 60,000 words with notes and references in the end. But there was a time that the book was actually twice that length. And let me explain. When I write something, I always look at the scientific literature and then I write this synopsis of it. And that is my first draft. And then I just sort of put aside my scientific hat and then say, why would anyone who's not a scientist be interested in this? And then at that point, I probably cut about 50 to 60% of what I've written. And then after that, I go back into sort of this third stage of putting it into context, putting anecdotes, narratives, and things that people find interesting in terms of adding quote unquote color to what I've written. So it's definitely been a different process, but I think having a book allows us a lot more than either even an article or a news report. Definitely.
Thanks, Anirban. I think it's just deep dive into COVID-19 and the book, and sure. I will invite Madhura to ask the first question, and I would also request the audience to put in their questions in Q&A, and we will take them up after the first round of discussion questions.
Anirban, I'm going to thanks Shambhavi. Anirban, I'm actually going to take over from a topic that you mentioned, vaccines, which is of great interest to my cohort in the Takshashila policy course on health and life sciences. So in the book, actually, you mentioned that vaccinations rather than vaccines are one of the keys to slowing down the spread of this infectious disease. And as vaccinations are sort of being rolled across the world, the recurring themes of this pandemic, which is conflicting information and questions about the scientific process, they're continuing to create doubt, both in the minds of the general population and also, sort of what questions are being put to the administrations. So what is your opinion about the design of this vaccination process, the vaccination process per se, especially in India, because of the challenges of the massive population size and our storage and logistics issues as we look ahead? What do you think is the key to execute vaccinations in a manner that will possibly work in India?
It's a great question. Before I answer that, I want to first of all say that this has been a mammoth effort by a lot of scientists and a lot of people to get these vaccines out on time. And I think what we often do is we get into, as we are liable to do, is to get into a lot of the details while forgetting the big picture of what a daunting task this was to get the vaccines, that the trials were all done properly, that we have multiple vaccines. And if you look back, even to what people were thinking in October and November, and this sort of thought that we might get 50% efficacy vaccines and that would be fine. The vaccines that we have are phenomenal with respect to that. I think that part of the message has gotten lost as now we're comparing various vaccines against one another.
Yes, yes.
Getting on to the second part of this question that you asked. Well, getting a vaccine is obviously a scientific and medical problem. Getting a vaccine manufactured at scale is an operational problem. Getting a vaccine delivered and everywhere else is an economic problem. But getting people vaccinated requires understanding of social aspects of it. So we need sort of this holistic approach. And I think a lot of these, what we've seen is a lot of rumors have been coming about regarding how effective the vaccines are. First of all, whether the vaccines are necessary or not. I think the first thing that we have to do is we have to start from the idea that this is something that affects everyone, and we want to engage in a dialogue, that basically we don't want to dismiss anyone's fears, first of all. Second, we want to understand from a social perspective that that there are things that we can do to increase uptake of vaccines. For example, if prominent people take vaccines and they're fine, it's one thing, and I've noticed this across the last few months, is you can say, okay, the trial was set up this way, the efficacy was this much, the vaccine is safe, but ultimately people notice what their friends and relatives do. So even with my mother and my relatives, it's almost like a one-on-one conversation with them to tell them about whether vaccines work or not. A couple of other things that we know from the past is paying people to get vaccinated does not work. It backfires because it tends to put into their mind this assumption that there's something wrong with it. Otherwise, why would you pay me to do something that's for my health benefit? So I think that's the key aspect of this as well, is that we have to engage in a dialogue, and we have to accentuate and mention the positives. As far as the negatives, the one thing that I'll mention is that we're seeing a lot of points about, okay, this what is happening with this blood clot, or somebody died, or allergic reactions.
Yes.
I want to point out, and I think we realize this, but the way that it's presented, it doesn't always come across, is that just because something follows something doesn't mean it happened because of something. I mean, something can happen at a later date that could be completely unrelated. And so far, with these vaccines, we know that they're safe. We don't have a single well-documented, established correlation and causation of any major adverse effect in the general population. There have been some cases in elderly people above 85 in one country, but again, we don't have that direct correlation. So I think all of us bear a responsibility to deal with this information responsibly. Because if somebody sees like this in the news, that okay, and I just saw one earlier today that some number of people were being observed for about 20-25 minutes after they got the injection. That is normal, actually. Even after people get flu shots, and maybe because people don't normally get adult flu shots, you have to sit there for 15, 20 minutes. So we shouldn't instill that sense of fear in people.
Right.
Thanks, Anirban. And thank you for highlighting the excellent progress scientists have made. I remember, I think in May or June, we started an internal debate in Takshashila on how soon will the vaccine be here. And Nitin beat us all because I think as a scientist, I was like, no, it can't come so quickly. And Nitin was like, no, we are seeing an unprecedented effort here. And we got the vaccine, he won the bet.
Yeah.
It has been simply fabulous. I just want to jump in with a question on vaccines since you brought it up before I hand it over to Pranati. And that is on, you mentioned about vaccine efficacy. And in the book, you talk about the fact that vaccines have can achieve one of three things or all three things, right? It can either prevent infections, it can prevent symptomatic COVID-19, or a vaccine can prevent severe COVID-19. In the middle of a pandemic, which of these aspects do you think is the most important, and how can we even compare across all the data that is coming through? Because the designs are very different, right? We saw Sinopharm in Brazil, which was looking at mild and symptomatic and gave about 60% efficacy versus some of the American vaccines, which were looking at only severe cases and were giving 94%. And all you see in mainstream media is 94 versus 62. And how do you even begin to think and wrap your head around all of these numbers?
And it's a good question. Everyone is asking this question or thinking about it. Is like, it's almost like we now have a menu, and like you go to order a dosa, and it's like, okay, which one? If I had a choice, which vaccine would I take? And the thing is, basically, I would take the first vaccine that would be offered to me because they are all effective to various different things that were checked. The criteria and the time point and the endpoints for each of these vaccine trials were slightly different. So you asked me what is most important, like is it infection, preventing infection, that is the spread of the disease, is it preventing severe disease and hospitalizations or just regular disease. And all of or most of the primary endpoints for this were disease with secondary examination of infection or serious cases. I would say that because, so the pandemic is serious and we've had to take measures because people are dying. And I think as healthcare professionals or folks worked in allied areas, that is number one. I think we should keep track of that as like, if we can prevent deaths, and then secondly, if we can prevent hospitalizations, use of critical care facilities, ventilators, and these long-term sequelae of long COVID or problems to the heart and lungs and things like that. And if by virtue of vaccination, we can make COVID into something like the flu or the cold, where it's like even a mild symptomatic or asymptomatic disease, then that is a win. And I think that message is also getting lost, because I've heard people who said, well, I got 2 shots, but then I heard about somebody who transmitted the disease to someone else. That's not, I think we want everything. And I think that's become a little bit of the problem. But what we have seen, I think the positive of this is what we have seen is that post some of these trials in countries that have done a very high proportion of their population has been vaccinated, such as Israel. And this information came in the last few weeks. So this is hinted at, but not in the book. What they've noticed is that the infections have also gone down. So while that was not, and this was for the Pfizer mRNA vaccine, while this was not a primary endpoint for the trial itself, we can expect that there will be a reduction in some infections. And I think that's going to be very, very helpful as we come to terms with these new variants of concern that I think people are worried about now.
Cool, thank you. Pranati, on to you.
Yeah, hi Anirban. So you mentioned earlier about kind of the social aspect of trying to resolve this disease. So one of the things that numerous politicians said during 2020 was, I believe in science and I'm willing to follow the science. And yet, as you wrote in the book, there is a very big difference between a clinician and an epidemiologist. And there's a further difference between a researcher and a policymaker. So we've seen responses led by administrators in some countries and epidemiologists in others. So what lessons do you think we've learned from this pandemic in terms of policy making for vaccines? And what path would you personally recommend going forward?
So I think one thing that we've all learned is a good dose of humility is very, very helpful. So it's like just there's a saying, one swallow doesn't make a summer, one wave doesn't make a pandemic. So a lot of the countries that got through that first wave and were lauded for that, for their Germany, for example, is now facing, because of the variant of concern, is now facing another crisis. So one key lesson is the pandemic isn't over for any single country until it's over for the entire world. And I think that is a key message that we have to, in addition to humility, that we have to remember. And then the other piece is that different countries will have different approaches. Small countries versus large heterogeneous countries will have other approaches. One of the key learning aspects of this pandemic is that in the fog of war, especially in March, a lot of countries that acted early and acted decisively did fare better than other countries that did not, even though all the information was not available. It allowed for scientists to gather information. It allowed for a number of things to happen. And so I think that 1 year now, we're at the stage where we have vaccines. So we have a number of tools in our arsenal. As far as which types of healthcare workers or people we should listen to first, I think public health takes primacy. And the reason for that is that sometimes the other stuff, the epidemiology, the virology, the microbiology takes time. And I'll give you two examples of this. In September, India was going through like this peak. And then October, November, December, we went through this decline. And by January, just a few months ago, the headlines all over India and even in other parts of the world, NPR had this piece about, well, what did India do right to get, and some people said, Wall Street Journal said it was masking. Some people said we had a high percentage of reinfection or immunity from other coronaviruses and other infections. Some people said it was the weather. And it was a whole number of theories. And we don't know what the theories are and which one is valid. That might take 6 months to a year. But we know that there was something that happened at that point that reduced the curve. Now we're seeing an increase again in other parts of the country, and it could be because of the variants of concern. That's a very plausible explanation, but we don't know that for sure. I think we can wait for that data, or we could go with the healthcare initiatives right now, and then just move forward with that. And I think in those cases, we sort of have to go with what the healthcare dictates, especially with the variants of concern. I remember in December, a lot of virologists were saying it is very, very unlikely for these variants of concern to be increasing infectiousness, immune escape, and mortality. But with some of those variants, it turned out to be true. So we have to follow. The information from the clinicians and from the public healthcare workers first.
Makes sense.
Thanks, Anirban. I think you could write a sequel on the theories of why some countries have done better, separating fact from fiction. Next, Vinayak.
Yeah, hey, Anirban. So on that note, what Champi just said, separating fact from fiction, I really like that tagline on the book. But what I find more challenging is perhaps trying to parse through multiple sources. We had Dr. Fauci, who was criticized, for his herd immunity goalpost by other scientists as well. So as someone who's written a very thoroughly researched book, how did you encounter any such challenges or dilemmas when faced with such multiple sources of facts? And I ask that because the scientific community in general has really struggled with communication with the general public. So would you have any recommendations for that?
Yeah, it definitely changes over. I mean, science works in a way where we have new information and our ideas change over time. The public necessarily does not see it that way. They see it as like, okay, you were wrong early on. Like, okay, you told us that masks don't work. Well, we didn't have information on that. Or somebody said, for whatever reason, there was a miscommunication with masks, definitely, in parts of the world. There was a miscommunication with a number of drugs early on that people thought worked, which didn't work as well as expected. On the positive front, I think people were very worried about surfaces and objects early on last year. People were even like washing vegetables, leaving them outside. Now we know that that's not a major way that how this. So there are aspects of this that are positive as well. But I think what we have to look at is like, who is the source of this information, where it was published, how well established it is, and whether it fits with common sense. I mean, so I can recall one piece of this that basically missed all of these, and it appeared in a prestigious newspaper like The Guardian last year. And this was this indication that that smokers had and this came out in WhatsApp and everywhere else as well. And it was actually in The Guardian, and it got like a number of hits. So if the journalists had dug a little deeper, then what would have been found is that this was the basis of not any type of scientific, rigorously done, statistically powered study, but a questionnaire. And then the questionnaire at one single hospital in France, this questionnaire was written up as a perspective viewpoint. It was not even a peer-reviewed paper that was put on a social sciences preprint server by a scientist who is a neuroscientist. So at multiple levels, this could have been checked and vetted by someone. And this was outside the expertise area of the person. This was a retired neuroscientist. But this was not vetted at that point. So I think, and it didn't fit even the smell test of common sense of why something might happen. But this was taken up, and this is one example of this. I think another thing that we've often tried to do is to inform people that to stick away from binaries of does this work or doesn't it work? And I think we want to give the bigger message and the broader picture, but we also want to tell them that there are no absolutes. There isn't really no black and white. And I think the one thing where this came up is with with immunity in reinfections. At one point, I think you'll recall, the discussion was, okay, we know that immunity post-infection in most people who are symptomatic last for at least 6 months. Now, this was sort of fashioned and became in the news media, and broadly speaking, immunity only lasts for 6 months. No, of course not. We only had data for 6 months. And so this is another place where it was not sort of this black and white, but it became like this black and white situation. So I think definitely we have to keep these types of things in mind.
Right, thank you.
Thanks. I'm going to pose a question that Nitin has put on the Q&A. And again, I urge all participants to ask the questions in Q&A. Nitin says, hi, Anirban, welcome to Takshashila. Could you share the main arguments and insights from the book? Will help those of us who have not read it yet.
Very, very difficult to summarize a book on the spot. But my take of this was when I started writing the book, I obviously took a very scientific perspective and bringing my own background to this. From that perspective, what I will say is that this is not the first pandemic that we face. This is a big one. This is not the last pandemic we'll face. Many of us will face pandemics. We are noticing this more because we seem to stay isolated and consider ourselves separated from the rest of the environment, where there are animals that actually through these zoonoses spread diseases, especially viruses, to us. So what most people don't know is that at the rate of 2 or 3 new viruses, they are appearing in humans almost every year on average. So this is a fairly common occurrence. Now, this one was obviously a big one. Scientists have been talking about a pandemic caused by a respiratory virus because of the characteristics of this. And we had been preparing for an influenza virus pandemic. But this is a big one because of how it spread and the lethality associated with it. But this is not the last one. And I think the lessons that we can learn from this are the world reacted from the positives, they reacted in a way that wouldn't have been possible before. So science occurred very, very fast, and we have lessons for future pandemics. But some of the things that caused this pandemic, the drivers, they still exist. And so we should be concerned about this and just say, okay, we can't go back to normal after this, or business as usual as well. It's a black swan event because we weren't prepared for it. But if we, now it shouldn't be, if another pandemic happens, it shouldn't be a black swan event. So there are things that we can do. So I think that's sort of the bigger message. And our learnings from this will be relevant towards other crises that we face, such as climate change. And that is an existential crisis. And so starting from that scientific perspective, I think what I came to better appreciate is the social aspects of this, that science does not work in a vacuum. It alone is not going to save us. We have to think about the social aspects of this as well. Thank you for the question.
Right, Nitin, that's a follow-up question. Would you say that early mistakes and screw-ups by Western countries exacerbated the pandemic around the world? Example, the mask issue, and more recently, EU's knee-jerk reaction to AstraZeneca Oxford vaccine.
Well, definitely the numbers show that Western countries have suffered, at least during that first year, disproportionately in terms of the numbers of people who have died from it. A part of that you could say is because of the demographics, maybe older people are there. But one lesson that we have is if we look at Hong Kong or Singapore or Korea or Japan, Australia, New Zealand, Rwanda, and I mentioned these countries in other places as well. Countries that took it seriously and dealt with it effectively, often because they deal with infectious diseases on a regular basis, fared better. I mean, in India, you're always thinking about where is this water coming from? How long can I sit here without being bitten by a mosquito? Is this person sitting next to me and coughing? Does this person have a respiratory disease? In the Western world, they've gotten past like worrying about malaria or cholera. And in a sense, that may have been detrimental in taking seriously, even when it was known in January, at the end of January and February, that the warning signs were there. I mean, China is fairly advanced in terms of their ability to react to this. And when this was happening in Wuhan, that was something to be noticed. So other countries that also dealt with SARS years ago, they tended to fare better. So yes, I think there is truth to that assumption.
Thank you. We have another audience question. Aditya Parikh asks, how do you see Russia's confidence in Sputnik 5, giving it clearance way before all the stages of trials were over?
So it is an mRNA vaccine and it is being provided in other parts of the world. So without going back to what they said early on, which we always have to deal with skepticism, once we did run the trials and they got the numbers, they were in line and consistent with the efficacy numbers above 90% for the Moderna and the Pfizer. So I don't have any reason to doubt that based on the class of vaccines and how they match up. So the thing is, if it had been a different class of vaccines, or if other vaccines in that class were 60 to 70% efficacy, and this one would have been above 90%, then the question would have come up, why is this one different? But it seems to match the other ones right now.
Thanks, Anirban. Take another question from Madhura. Madhura, you're on mute.
Sorry. Anirban, actually, I sort of linked to what you were talking about before. We were talking about Sputnik, and I was thinking about it as a scientist. You know, in science, trial and observation is kind of a key part of the experimental process. And in a sense, the way most administrations have dealt with this pandemic, has, as you've detailed in the book, has also been by looking at what works and continuing to do it, and acknowledging and abandoning things that have not worked. For example, masks early on, certain drugs that they thought would work and then didn't work. And I think that medical care and science have looked at measures that work in a global setting. So I think medical communities across the world have sort of spoken to each other and have dealt with it in a manner that works together. But obviously, countries around the world also have cultural differences that have determined sort of responses that are different. As you were saying, countries like India or Rwanda or Southeast Asia that deal with it differently to the West. So in such a scenario, how do we create a blueprint to deal with the next global pandemic? Where not just the medical community and the administrations are involved, but it's also the general population themselves. And they're also talking to each other much more. As you said, with social media, people are, information is able to get across countries much faster. And obviously they're being interpreted in different ways, depending on the culture of the population. And
yeah, it's a great question. And as I mentioned in the book, this is the first this is not the first pandemic of the social media era, H1N1 of 2009 was, but this is the first pandemic of flattening the curve as something that everyone looked at early on as something that we wanted to do, where we could just look at and we're still looking at the daily numbers every day. I mean, this is possible often from the comforts of our homes, which was not possible during any earlier pandemic. So I think a lot of comparisons early on have been made against 1918 and the Spanish flu. I don't think that's fair. That was like before, in the infancy of even medicine. So I don't think that's a good blueprint for this. I think no one alive is going to forget this one. So I think if anything ever happens again, people will not doubt some of the things, definitely masks and things like that. But we have to move forward. I was very heartened to see, okay, so this is at the individual level.
Yes.
I think your question is more also at the country and the global level as well. At the country level, I was actually quite heartened to see increased allocation of funds in India's budget for building up infrastructure. We sort of tend to lionize Jugaad, this principle of like, okay, getting stuff together at the last minute. And I think our scientists did an amazing job last year of, when there was not enough testing, coming up with cheap tests, coming up with ventilators and things like that in a very quick amount of time. But I think in the next pandemic, the situation should be that we should be prepared beforehand. With infrastructure, with beds, and to be able to do that requires funding in advance. India in general is relatively well prepared to deal with medical crises on a national level because of our number of vaccine manufacturers and the strength of the pharmaceutical industry, and I would say the intellectual capital of the country compared to a lot of other countries. I mean, if we look at countries in Latin America and Africa, and India has been using vaccine diplomacy as well to get vaccines created in India to all of these other countries. What I think we will need after this is some level of maybe a Paris agreement for dealing with the next pandemic, and funding from governments, because the way the pharmaceutical industry works is they don't like to put in a lot of funding for diseases that don't exist, right? Because they can't recoup the cost. It takes so at that level, I think governments will have to come together. And there is, with these, I would say the silver lining of this is now we know that the mRNA vaccines and these new molecular platforms work very well. So we could start to envisage a situation where we can create vaccines for pandemics that haven't even occurred yet. So there is a trial underway for a pan-influenza vaccine for different subtypes. We could have a pan-coronavirus vaccine as well. That would be available or scalable in the future as well. And I think just getting the local communities involved in a One Health situation, where if they do identify, Thailand has done this quite well, where people have mobile apps, where if they notice that their birds, these are farmers, that their chickens or their ducks get sick, then they immediately key that in. And that could help prevent at an early stage or contain the next bird flu or avian flu spillover. So there are a lot of things that can be done.
Thanks, Anirban. Just a follow-on question. Do you think it might get too COVID-focused, our lessons for the next pandemic? Because this is so fresh in our mind and the impact has been so huge, that when we sit and draw lessons for future pandemic preparedness, it might just be about the respiratory disease that's coming and transmitting human to human, and we might forget about all the rest of the repertoire of diseases that might come through in other pathways.
There are a couple of ways to answer this question. One, I think, is if I take the broader view of microbiology, then yes, that is definitely a problem. That once a disease becomes less of an immediate crisis, then we forget about this. And I'm thinking of tuberculosis, which has TB has a major health burden, or malaria, which has killed more people in human history than any other disease. Or if we think about AIDS, HIV/AIDS, which after it became sort of this disease of a part of the world, Africa, similar to Ebola, then people stopped caring about it as much as they would have elsewhere. So we have to think about infectious diseases from a broader perspective. I think the second part of that question is respiratory diseases pose a unique threat that not even pandemics caused by waterborne diseases or from other manners of disease, HIV/AIDS, which is through blood transfusion and is a sexually transmitted disease. These are serious diseases, but there are control measures. Whereas for a respiratory disease and one caused by a virus, breathing is not optional. I mean, you can control the water, you can boil the water, you can do many things. But as we're seeing here, we're all, actually it's not true, we're not all breathing the same air. But by and large, the manner in which a respiratory disease is spread and how fast it cycles through as an acute infection makes it more possible to cause a pandemic, as opposed to a chronic disease that maybe stays dormant for many years and then comes up and pops up in certain people. So the threat definitely, I think, is from all infectious diseases is large, but respiratory diseases and respiratory viruses in particular represent, in my view, the greatest threat.
Right, yeah, I agree. Next, Pranati.
Yeah, so I mean, we referred earlier to the challenges of writing the book because, information keeps coming in day by day that changes, opinion. But you do mention in your book that school closures may have been warranted because children were found to have a high prevalence of infection. But right now, the US's current recommendation for schools is to let them remain open. And I mean, I find right now that a lot of parents are trying to find that balance between, their responsibilities and their children's safety. So what is your opinion on school openings as they've been done in the US and in India as well?
Yeah, it's a great question. And again, this is sort of there is no absolute risk. Risk is sort of this thing that you have to weigh the benefits versus the potential disadvantages. When this pandemic first started, all of the information that we had was from a pandemic preparedness document based on influenza. And as we know, influenza, typically, most forms of influenza, I mean, there were exceptions like the Spanish flu, but usually it's spread mostly or in a major way by children. And children tend to get sick more from influenza and tend to suffer most of the worst consequences. As we found out more about COVID-19, I would say another one of the sort of silver linings in these dark clouds has been that children tend to be less affected, both in terms of symptomatic infections, but also in terms of how they spread the disease. And although there were some early indications of some very tragic deaths of this Kawasaki-like multi-inflammatory disorder, the prevalence of this is very, very low. It's like, I think, in 1 in 300,000 or 1 in 400,000. Even though every child death is extremely tragic, that's still very, very low numbers. What we saw early on in parts of the world, like that open schools early, like Israel did this. And what they noticed is that there were spreading events, super spreader events in Italy, in Israel at that time. And so while that data was being collected, it was prudent to keep schools closed at that time. And I know everybody hates virtual schools and virtual schooling, especially after a year. I think the second piece of this was that children were seen not so much for how sick they would get, but that they would transmit the disease on to their parents, to teachers, to grandparents, and to others. Now, the way that the vaccinations have occurred is the highest risk factor people in most countries, so the grandparents, the teachers, and many of the parents have now been vaccinated. So the risk is now definitely lower. So in a phased manner, I think school openings are warranted in countries that have been able to vaccinate, because now the grandparents, the parents, the teachers are safe.
Thank you.
Thanks, Anirban. Before Vinayak will ask a question, I will again encourage the audience to post their questions in Q&A. We will take them up after the next question.
Yeah. So one of the things that I really found interesting was how the perception of the general public has changed in terms of what they expect from the scientific community. Typically, we notice that relation or that equation to be more paternalistic. That is, do this, wear a mask, stay away from people. And right now we are kind of seeing this sort of outrage over the donut for vaccine campaign in the US. So, and people, endocrinologists have gone crazy that how can you encourage people from eating? Encourage people to eat donuts. So I feel that a lot of it is a little bit off. But do you think that there needs to be a change in the way how scientists should communicate? Do they need to be more paternalistic or give more autonomy to people, which is what I believe the demand is?
I think it runs the spectrum. I think some scientists have done a really, really good job of breaking things down. And I very much envy their ability to break down extremely complex scientific facts into simple ways, especially, and then using visual models as well of especially the multiple layers, using the cheese model. The cheese has holes, and as it goes through, and things like that. Just, I think using visual models is one way. Second is people have been, those who have been able to successfully use stories and narratives. I think that's one of the big learnings for me, is that you can throw a lot of data, a lot of numbers and percentages at people, but ultimately, often what they find very compelling is like the personal stories and the narratives and things like that. So I would say that's the second thing. Another thing I would say is that we should definitely engage with the public early on and assume positive intent and sort of a positivity that their questions are genuine. I'm not talking about the fringe, the conspiracy theorists. We're talking about like injecting a microchip or those people, but people who have legitimate concerns or worries about that, and then engaging in the dialogue as if it is concerning their own public health. And I think through that process, the questions are genuine by and large, apart from, and you can pick out the ones that are not fairly easily.
Right.
Thank you.
Thank you.
Thanks, Anirban. I think as we wait for audience questions, I had another question to ask you. You said in the book that you disagree with the notion that drug trials are fine at other times, but not during a pandemic. Could you elaborate on that and why perhaps robust clinical trial design is of most importance during the pandemic?
So this is something that is being debated, like how important are drug trials, or the need to go through the full 3 phases of phase 1, phase 2, phase 3 trials for drugs. Also, I would say for vaccines. Part of it is to let the public know that these are perfectly vetted and safe drugs, as opposed to anything that can be put on the market. So you have that certification. But the other piece of this is that it's a learning experience. I think in 2014, what the World Health Organization did as this epidemic of Ebola was raging, is some of the drugs that were tried during that, hydroxychloroquine, chloroquine, favipiravir. These were the drugs that were actually, some of them were actually used also during the COVID-19 pandemic early on. And what they found is that none of these drugs worked for Ebola, but they had been used in this emergency case situation. And they were used in this emergency authorization scenario for COVID-19 as well. And none of them seem to work at the level that initially it had been. And so what that does is that erodes the sense of confidence of the public in the entire process itself, and say, okay, you guys got this wrong, you guys don't know anything. I think that's one of the key factors. And then I would say, secondly, the other part of that is that the amount of energy, the time, and the effort that was put into those discussions could have been used for something else. There is never sort of this infinite amount of resources that we can put into any number of clinical trials. So that was a lot of time wasted. I see the flip side of that as well, to be honest. If people say, okay, why can't we just give this drug to someone? And I would say that maybe that is the case if it's a well-established drug that has limited side effects, and you just want to test it out while trials are being done in the background. So if it's like something like aspirin, is widely available, cheap, and doesn't have these other side effects. And we see that in this particular case, that seems to be helping. Then while the trials are run, then that could be given. But by and large, the lessons and the recommendations of the World Health Organization seem to be valid to me. So we need to have drugs that actually have been shown to work in trials, even during a pandemic.
Thanks. I think a lot of conversation around either vaccines or drugs for COVID-19 have operated at two levels. One's at the individual level and the other is the population level, right? Particularly with vaccines. Because when we talk about efficacy rates, obviously people who are taking the vaccine at the individual level want to be protected, but we know that not everyone will be. And therefore you have to still wear masks. And that kind of, again, adds a question and a hesitancy to people. And I just wonder about how we can better communicate the fact that this is in population interest. It might not always be in individual interest.
Yeah, and I think that's you mentioned the point around masks, and I think that's one of the key points as well, is that you are, as part of your community now, the broader community, you are responsible for everyone else. So while you may not get sick, you're wearing the mask so that in case that, and this has to do with what we learned about masks in general as well, is that it's protecting more in the sort of the outward direction than even in the inward direction. I think one of the things around that is the concept of this the herd immunity. Is like, okay, at an individual level, I am taking this this to help me and so that I can live my normal life, but it also helps toward reaching a threshold of community immunity, so that even if some people don't take the vaccine, then they get protected as well.
Vinayak, I believe you have another question.
Yeah, I mean, I think you mentioned a little bit about, compelling narratives. And I found this point in your book very interesting when you said that all of us bring something to the table, or in terms of our experience, we bring our own dispositions, beliefs, and values. So I was very curious to know that what do you think will influence your recall of this experience? Will it be the microbiologist or the author, or, just a general citizen who's sort of seen these things unfold?
That is a good question. I think at the most basic level, I will remember this just like everyone else, as this sort of thinking about and worrying about my family, my friends being stuck in this work at home situation. And then the way I dealt with it is going to be different from the way anyone else deals with it. And that applies for everyone else. I think the mindset that we have, those of us who are analytical, when we face a problem, we always try to seek out as much information. For some other people, that information can be overwhelming as well. Say, okay, just tell me what to do. I don't want information. There are some people like that. And some people are also very pessimistic. They bring their outlook in terms of that. I think scientists and physicians and healthcare providers in general are optimistic because we also have the history of these disciplines that are fairly young. I mean, 100, 150 years ago, nothing really existed. And so I think we come from that place of optimism in our professional life. On a personal level, though, you have the same exact fears. I mean, I think as Pranati was asking a little while ago about sending children to school, or what do you do about your parents and convincing them to get vaccinated, and your neighbors and things like that. But overwhelmingly, everyone I know feels exhausted in a sense after a year. There's this sense of exhaustion and irritation. And broadly speaking, some of the things that I will come out of this pandemic with is, I mentioned all the positives, but just the sense of all the disparities that are there, the disparities that, and I mentioned this in our book, the disparities that we have in our society get accentuated during a pandemic. We say we are all in this together, but that's not actually true. We are not in it together in the same sense of being it. And I think there are ways, just even some vignettes and some headlines point out to that. I mean, in certain parts of the world, we are fed up of these online meetings and Zoom, but we have the privilege of being able to work from home. Whereas a lot of emergency workers and minorities in various parts of the world bore the brunt of this because they were called to put themselves in harm's way first for that. So there is that social piece of disparity. We have people who are undergoing plastic surgery because they don't like the way they look in Zoom. And on the other hand, we have people who are not getting their necessary childhood immunizations because you cannot do a telemedicine approach for immunizations as well. You have people who are sneaking into golf courses to play a round of golf during a lockdown. And then you have people who don't know when they're going to get their next meal, and they have to walk and they have to bike across an entire country on an empty stomach. So I think these disparities are one piece of this that will stay with me as long as I remember this pandemic.
I think that was really well put, and I think we all relate to that as well to an extent.
Yeah, thank you, Anirban. That was, there's a lot of parts. I had a question about what you were speaking, right? Like initially there was a lot of fear of COVID-19 when it came. And a lot of the fear also was rooted in the fact that we did not know a lot about the virus. And I think much of our response was driven by the fear of the unknown, and part of it was driven by the fear of the virus. How do you think this will play out in the future? So now, I know, for example, in India, we are starting this initiative where we're going to identify unknown pathogens. So there's going to be a focused research area on trying to see what all viruses are around us, what all pathogens are around us, and whether we can be better prepared. Under One Health, do you think that is going to be a very important part of maintaining public health security in the future?
Yes, I do. And I see this as very much as a positive. I always believe that it is better to know than to not know about something, even if it is information that is not positive or maybe disappointing, because as I mentioned, the drivers are there for additional infectious diseases to occur. So if we don't pay attention to them, it doesn't mean that they go away. They still exist. So I think by focusing more on them and paying more attention to them, I think that will be positive. And people will be prepared. I know nobody wants to think about the next one right now, but again, a second event would be independent of this. That's what I'm saying. None of this is related. So if we are extremely unlucky and there is an influenza pandemic, that has absolutely nothing to do with how many years ago or when a coronavirus pandemic occurred. So hopefully we can stop it and we'll be better prepared.
I think we're almost out of time, but all the panelists agreed on one final question, which was to ask you what would be your 3 recommendations for future pandemic preparation.
Okay, 3. Let me think about this. Trust the science, definitely. The science, when all the things were problematic and when we were, when we thought that there was going to be like no no tools or no ways to fight this, then ultimately it was the science that that came through. Remain optimistic. I know this is hard on a day-to-day basis, but we have been through so much. And I mean, as people, as humans, we have always faced infectious diseases. I think more than 8% of our genome is of viral origin, that's come from viruses. So as long as we exist, there will be a constant struggle and this sort of battle between infectious disease. We have to remain positive in light of this, because we've succeeded. We have medicines, we have many things now. And if we think about past diseases like smallpox, they have been eradicated. So I would say that's the second thing. And then the third is build up the infrastructure in between the time, or be prepared for that. So even within India, we see that the states that fared relatively well, even though they were hit early, are the ones that spent a lot more of their money, of their finances in building up qualified staff in hospitals and things like that. And so in India, we have this huge disparity of so let's say a state like Kerala, or the states of the south are actually very, very strong in healthcare compared to say Jharkhand or Bihar. And so it's almost like it's one country, but there's this disparity, and I think we need to change that. So those are my top three.
Thank you, Anirban. Thank you for a wonderful discussion. Thank you to our discussants and audience for their participation. Before we close, just please check out our upcoming events at the Takshashila website, or you can also follow us on Twitter at Takshashila INST, where we will routinely put out information on upcoming events. Thank you all.
Thank you so much. It was a pleasure.